In the wake of social unrest and transparency in racial division and injustice, there's no better time than to show this fact that I'm about to show today. I want to stress to the public that I post these pathology videos to show to the public the scientific value that pathology brings to clinical medicine. Even with limited or no antecedent clinical data, examination of tissue after death brings light to just how we trace the facts that science and pathology can predict. In short, the autopsy reveals the whole truth and nothing but the truth. So with that, I would like to show the histopathology evidence as to a patient, in this particular case, a 45-year-old male, not being diagnosed with inflammatory bowel disease until death. So with this, I would like to show the histopathology evidence as to, in this case, a patient of 45 years old being diagnosed with inflammatory bowel disease until death. Not until death, actually, when he was diagnosed. More evidence in healthcare disparity after being in a hospital for more than 2 weeks prior to being discharged from the hospital and dying after a dialysis clinic visit. So we began by doing a low power scanning view of a random colonic section as I began to unveil the evidence of it as to how I derived at the final diagnosis. So I'm going to start here at this power, but here's the, I want you to focus on this area because I'm going to come back to this area to explain what we're seeing. But I'm going to go over a few, and what I want to show you that not on this section of the colon, but if you look at this is section of colon. If you look at this section of colon here, this mucosa, it looks like it's relatively normal from the untrained eye. And in fact, even from a trained eye, you see you see tubular-like glands that are showing evidence of lining up for the most part. Nice space arrangement between the glands, nice amount of lamina propria and subcu, a lamina propria tissue in between the glands. But as we continue to go over, you start seeing still relatively intact glands. So this is relatively normal colonic mucosa. We talk about skip lesion, as I'm going to readdress that as I get back to the diagnosis. So I'm going to go back over here so we don't prolong the inevitable. So now as I continue to go around, you start seeing some changes within the glands. So you start seeing some curving of the glands, a little irregular spacing of the glands. And I'm going to go down even further now as I talk about the histology in this particular area of the colonic section. Now, this is a random colon, and I'll tell you the importance of that. So we continue to see a little disorganization of the glands, a little loss of goblet cells. So the glands are regenerative in this particular biopsy. Here's evidence of there being more irregularly spaced out, maybe perhaps an early bifurcation of a gland, even a little loss of maybe even, let me see if I can go down. That might be even a granuloma that I may not have seen before. And all of this will come to what I'm saying about this as I get more into it. But I just want to make sure that this is not a granuloma. Now, that's probably a gland that is dropping out. But the other part I want to show you as we get to the nitty-gritty of this histology is that look at the lamina propria, slightly expanded by lymphocytes, histiocytes, some plasma cells are there, and some scattered eosinophils. So eosinophils is a very good idea because in this case, you want to make sure that you're timing the pathology. But in this case, the pathology doesn't need any self-explanation it's self-explanatory in terms of the timing. Chronic inflammatory bowel disease is a long term process. So it's not a short-term process. You can see a little more eosinophils, a little more irregular spacing of the glands, See that? You don't see the just, and then, so now I'm going to go to my next slide to show you how I put it all together. Okay, so I'm going to end this slide and go to the next slide. So now we're going to do a scanning view of the inflamed small intestine. And this small intestine is from the perhaps distal jejunum, or mid to distal jejunum slash proximal ileum. So and I'm taking it because I was actually, when you're doing the autopsy, you get a chance to see the whole intestinal structure. So therefore, and that's where I took this sample from somewhere along the mid to maybe slightly distal and proximal ileum is where this segment of colon was taken from. But I want to explain the pathology here as we zero in on it. And from a first glance, you say, oh, that looks relatively normal. But keep watching. Well, first of all, you shouldn't see this much lymphoid aggregate. Well, you can see some lymphoid aggregates as we go towards the distal jejunum and proximal ileum. Remember, pious patches with the ileum is what defines the ileum. But I wanted to let you know that I don't think that this is normal mucosa. And here's one reason why, is that you see these things here that are coming into view as I zero in. Now, this is inflamed intestine, and I'll tell you how I know this once I get there. But you see this. Those are what we call poorly formed granulomas in the mucosa. And that's going to be important when we continue to hone in on the diagnosis of what I think is going on here, okay? So we're going to kind of try to keep it in focus. It's going to go in and out of focus because this is real time. See a little, okay. So let me go back. So I don't want to waste a lot of time, so I'm going to go back to, so you do see the granulomas, which I missed actually early on in my report, but I see them here now. So this is really confirming my report. So we see that, and then I want to kind of scan on over to get to the nitty gritty. All right, let me see. I want to kind of, okay, just keep on bearing with me as I continue to, let me just go back on lower power so we can see where we are. Because I want you to see the gestalt of what I'm trying to get at here. Okay, maybe. Okay, I think we're getting there. We're slowly but surely getting there, so bear with me. And it may or may not be on this particular image. You know what? I think it. Let me get there. See, that's the only thing when I'm looking at this image as you see it in real time. I'm trying to get to the point where the mucosa is ulcerated and extending into the underlying connective tissue. And so far so good. Maybe this is not the section I wanted to show. No, it's not in this one. So let me take this image off, and I'm going to immediately put another image on. Okay, and this is still a small bowel mucosa, part of where it was perforated. So let me just try to go to the point that I want to kind of highlight. Okay, now we're getting into a little mucosal herniation or fistula tract formation right there. And you can see the surrounding connective tissue is being inflamed. But let me just go back to the point of what I want to show. And you're seeing the slide. Look at that. That's nice mucosa, fistula tracking with attracting, I should say, within the muscular propria. Now that you can't explain that any other way, but to confirm that to know that is mucosal glands going in through the bowel wall there. Okay, and then now we're getting into submucosal tissue, more inflamed muscular propria tissue, and I'm going to go down to show you the inflammatory cells. And that's going to be a key component to this process once we get to the nitty-gritty of explaining the timing. Now, this is not something that occurred in a 24-hour period. This, you can see the organization as I'm skipping around now, but I'm getting to a point that you can see the organization of acute and chronic organizing serositis. Now, this takes a while to get something to develop like so. You get the scarring formation, you see the inflammation, but I'm jumping ahead to where, you look at this right here. There are some blood vessels that having a little form of clot, inflamed clot in it, which is when you got inflamed tissue, you're going to get some clotting in vascular tissue as well. And I'm going to keep on moving around as I'm not there with what I wanted to show, and we're going to get there though. So you're seeing all the tissue that I have, and let me just, here's more inflammation along the serosa as evidence of perforation. That's not the image I wanted to show. So let's go to the next slide. We're going to get there. Okay, that's just more evidence of the rupture. Let me see. And you look at the organization here, the inflammatory. Let me just go down just to show you this. I wanted to show you the ulceration part of the intestine, which obviously took place, because there was evidence of perforation. You see all this inflammation here. Now, some of this is a chronic inflammation. Chronic inflammation means it's more than a few weeks, and you're getting into months now that this has been here now. So, and let me just show you, just to convince you what these cells are. These are just not lymphocytes, but there are some histiocytes and plasma cells and even some eosinophils and this organized inflammatory component. You see the eosinophils, the histiocytes, and some plasma cells there. So this thing did not just occur within 24 or 48 hours. This thing has been here for some time now, maybe days, maybe even weeks. Okay, let me see. Let me just keep on. And then you start seeing some abscess tissue here, which goes with the perforation here. Okay, let me keep on going around. I wish I could show you the actual ulceration component. So let me just see if we're going to see the ulceration. You can see the inflamed muscular propria tissue, inflammation transcending the muscular propria into the serosa and even into the serosal fat and inflamed tissue there. Okay. But anyway, I trust you me, and I think I showed in the gross examination anyway that there was ulceration, there is a restriction of the bowel, there is narrowing of the lumen. So all in all, I interpreted these findings as compatible with inflammatory bowel disease, most likely probably Crohn's disease, given the skip pattern, the granulomas, and even the fistula tracting. So this person went to the hospital 2 weeks prior to death, was diagnosed with kidney disease. And I'll show you the kidney example where he was, kidney section, where he was dialyzed and ultimately died within a few hours of being dialyzed after complaining that he didn't feel well. Went home and died. So I want to go and show you his kidneys just to show you some pathology changing of the kidneys, of his kidneys. So here's a section of the kidney as I peruse around. And on first glance, you see nice glomeruli. Some are showing a little slight mesangial cell hyperplasia. Now I'll go closer to show you some of that evidence there. But the tubules are nice, developed. I'm going to go down because first let me give you the overall gestalt. So you do see this moderate to intense lymphocytic infiltrate. So you got some evidence of interstitial nephritis. Let me go. It's more, and then I'll talk about the glomeruli after I show you the inflammation within the kidney itself. And that brings up, could this possibly be some sort of immune process involved in the kidney? Because there's an intense inflammatory component, but this could also be scarring. And then you see this right here was a nice little picture. And I'm going to talk about the glomeruli and the tubules, but let me go down and show you this part. So I interpreted these findings here. You see these little granulomas looking stuff here around what looked to be like urate-like crystals. I interpret that to be maybe some gouty deposits within the this inflamed kidney section. And there was a better view of where you see those like needle-like birefringence with some multinucleated giant cells and stuff like that. But just in what I want to go back to, because the main pathology as this person was being dialyzed, and you can see the tubules, while they do have some proteinaceous debris within them, they don't look that bad. There's some slight scarring around some of the tubules here, but you can also see some of the inflammatory cells around the connective tissue there. And look at this right here. Now, I'm interpreting this as a sclerotic glomeruli. Some of these are indeed glomerular sclerosis. So you do have some damage of the glomeruli here. And let me go around, but here's a nice looking, relatively normal, but not completely normal glomerulus, showing slight mesangial cell hyperplasia as I mentioned earlier. But again, look at the tubule next to it, very nicely normal. So some hypertensive damage, and I thought I saw some arterioles showing the onion skinning, you know, the concentric fibrosis, but I'm not sure if some of them are in here. But you can see even in some of the arteries, you see some of the, let me see if I go down, if I can go down without, okay, cool. So you're looking like this artery right here, arteriole here, showing some concentric fibrosis here. Okay, there's another artery there with some fibrosis. So you got the hypertensive damage as well. So I'm not saying this kidneys is completely normal, but because as it shows some hypertensive damage from long-term damage to the glomeruli from high blood pressure. But the tubules, although they do show some proteinaceous material there in the tubules, they don't look terrible. I mean, but there is some damage here. So we do see some damage to the kidneys. Look, that's a nice glomeruli. Take a picture of that one, because that is mesangial cell hyperplasia, classic textbook that you see with hypertensive kidney disease. All right, so there's some pathology there. Now, some of these tubules are now beginning to show some scarring fibrosis. So maybe, you know, this person also had a history of diabetes. So I think there is some diabetic and hypertensive kidney disease here. I don't think it's that advanced, but there's some definitely damage here. Again, this would have neatly required correlation with the antecedent record to see just to correlate with the EGFR, the creatinine, and the BUN. But be that as it may, this kidney doesn't look that terrible. If you looked at it grossly, it's a whole different story, and I'll add the gross videos as well. So there's some damage here. But the main issue is that I think this person went with an undiagnosed autoimmune disease that I'm thinking was Crohn's disease, and there was that I think still could have been diagnosed to assist this person. But again, there were some other issues here, like high blood pressure and diabetes.
So I've dissected and opened more of this loop of bowel, and you can see that is so real. I don't think I see a tumor, but this wall is kind of thickened, so I want to kind of study that a little more. But you can see that this is the source of peritonitis and perhaps even rupture of the intestine right here. But I want to kind of study that a little more to see if there is any tumor in that. But this looked like just all abscess tissue involved in this loop of bowel, so which probably perforated. So I have to kind of look at more of the clinical record to see what happened with that. But I think here is going to be the source of death. Ruptured intestine with peritonitis and sepsis. I think that's what we're going to lean towards. I don't see any tumor here, but I'm going to continue to dissect the loop of bowel. I bivalved one of the kidneys, and you can see that the cut surface is, there's a little catheter in this kidney, so definitely scarred down, and it's difficult to determine the cortical medullary junction. This is very severely damaged end-stage kidney disease. I don't see a tumor, but again, we have to look at the cut surface, and apparently there was some sort of catheter insertion, perhaps from stones or what have you, or from renal nephrosis. But kidney, swelling of the kidney. But we need to see by records what that was about. But there looked like some, I think that's blood clot. Let me take a look at it fresh. Yeah, that's just blood clot there. They kind of look like black stones, but I don't think those are stones. But we will see. This kidney is very damaged, so yeah, that's blood clot. Okay.